status is always best, so give the best therapy upfront. When you wait for them to relapse, the poor performance status and their old age may have a problem. Durable responses are achieved always with the early transplants. The autologous transplant usually has predictable toxicities, and when you wait for them to give a late transplant, they are more older, more comorbidities, more complications, and more mortalities. And either, you can say that transplant doesn't cure. So either the early or the late transplant doesn't cure the disease, but you achieve for a better PFS with an early transplant. And in the Indian setting, where the novel agent-based salvage therapy is yet to be widely affordable, I think early transplant is the way to go. Now, coming back to the second agenda, what would be the optimal mobilization strategy that you would use in your setting? So I will start from Dr. Anup.
So the standard what we go is 5 days of 4 days of GCSF, 10 miles per kg, and fifth day you do the harvest. And in our center, what study we do? We do a CD34 cell count on day 4, and based on the CD34 we decide about the Perixafor. Not in all cases.
And Dr. Smita, when will you try for a chemotherapy mobilization?
We have tried in a couple of patients with chemotherapy, but somehow the logistics are problem, especially the platelet count, the recovery of the platelet count during when we plan the harvest.
So
we are not following chemo mobilization as of now. It's stable GCSF mobilization or Perixafor in select group of patients depending on their previous lines of therapy received and some other risk factors, but we don't have currently CD34 to identify the patients. Either it's a upfront Perixafor for high risk patients or a salvage Perixafor for the first harvest is.
So you always monitor the CD34 pre?
No, we don't monitor pre-harvest CD34.
Okay. Dr. Subhash, your take on that?
Yeah, I don't know whether we are privileged or not privileged or whatever it is, but we used to have chemo GCSF for most of the myelomas and chemo GCSF with cyclophosphamide for myelomas and ESHAP, DHAP followed by harvest in a lymphoma.
So routinely for all patients?
This was 2 years ago. Once we had the generic Plaraxifers, almost all of our patients are mobilized with Plaraxifer and GCSF.
Upfront.
Yeah, the reason why it is we have found each day of hospital admission, each day of suboptimal mobilization actually increases the cost significantly. If I have to use chemo GCSF as what we have done before, we have to have 2 admissions. We have admission for a chemo GCSF, if you are going to do cyclophosphamide or etoposide GCSF, send them home because 90% of them will have severe thrombocytopenia or cytopenia, particularly thrombocytopenia at the end of harvest. So we can't go straight to a harvest at the time. So now with GCSF and Plaraxifer, we are having a sustained and a very good collection on the first day itself, and we give the melphalan on the same day, and then give the stem cells 24 hours later. Even though we have a cryopreservation unit on site, that reduces the cost of the cryo bags, the DMSOs, the liquid nitrogen and everything, and saves a lot of hassle for us. So we have the mobilization and the transplant on the same visit. So we use Plaraxifer and GCSF. We used to do preemptive, but we use as a routine.
And what's your practice in your hospital?
So me and Subhash come from the same cohort of thinking. But same knowledge in UK, we always did cyclo GCSF. One advantage is that you've actually got a deeper remission because you've given an additional cyclophosphamide, a big dose.
And how severe is the neutropenia and the
Because your collection is on day 7. So you normally give cyclophosphamide, say, on a Thursday, and you would collect on the following, the following Wednesday or Thursday.
And you don't encounter any of these patients to fall sick with neutropenic fever or?
Not generally.
Not
they're having cyclophosphamide and mescaline,
and
they're going home.
Throughout.
They're going home and coming back and having a peripheral CD34 counts checked, and then going on the machine whether you need a GCSF or whether you need a Perixafor. But in that way you get a deeper remission. Yes, your PFS probably are going to be longer, but for those patients you're going to cryopreserve the cells. In a clinical practice here, I don't use that because the cost is an implication, and I don't want to, the risk of toxicity is high. You've just given a big dose of cyclophosphamide and then you're going through autologous transplant. So for only one patient I've used in India is the one who has failed to mobilize with GCSF and an additional Perixafor. That is a patient whom I've given time, asked her to come back, so that the lymphopenia post Revlimid, the lenalidomide has gone away, and then I tried next time with cyclo-GCSF and an additional fluoroxyphor. I've not been successful. So I'm waiting for a bit more time to get over and then try another transplant.
So for the trainees and the residents here, these are the three strategies of mobilization. The first is the cytokine-based mobilization, where graphene is used, GCSF at 10 micrograms in 2 divided doses, 10 microgram per kg. And then you have hydrocyclophosphamide followed by GCSF, and then monitor the CD34 counts. If it is more than 10 million cells, begin the apheresis. Less than 10, continue GCSF till it becomes more than 10. And if it is less than 10 and the white blood cells are more than 1 for 3 days, then plerixafor needs to be started. And the dose of plerixafor is, if it is a creat clearance is more than 50, it's 0.24 mg per kg. And depending on the creat clearance less than 50, it has to be reduced to 0.16 mg per kg. Now, we discussed about what is beyond beam in lymphoma. In myeloma.
Before that, can I ask?
Yeah.
So, we are talking about the failure of mobilization. So, how do you define your failure? Once you do the harvest and then you check the bank CD34 and it's not adequate, then you are calling failure, or pre-harvest you are doing CD34, based on that you are calling?
Pre-harvest we do CD34. Suppose on the first day your count CD34 is only 10, you know that you're going to struggle. But we would give plerixafor on that day and try out the next day. So unless your CD34s are not even 10, I wouldn't put them on the machine, because you're not going to achieve enough. There is no point in collecting 2 and then saying you failed, because cost is the biggest implication here. So that's
and, for the center, those who don't have the in-house facility of CD34, so what they will do? So if they don't have the in-house CD34 facility.
I think once we've collected the cells, we're doing CD34, so it's not a big difficulty in establishing that service, because it makes sense for somebody. You put a line and then put them on a apheresis machine, and you can imagine that you've not been able to collect after 2 days. That will be a line cost, a patient coming, and it's very difficult to substantiate our expenses in a current setting of private healthcare. So I don't put in lines after one experience of failed mobilization. I always get the CD34s peripherally on the day of collection and then send the patient for a line. And we're preferring PICC lines, but of course, it's easy. If there is a renal problem, I would get a BASCAT. There is a potential renal problem. If not, I'm trying a PICC for a myeloma autos, not for lymphomas.
So the next one is Dr. Smita. Beyond melphalan, is there any role for addition of any other chemotherapeutic agents in myeloma autotransplant? We heard about what is beyond beam, replacing or adding medications in myeloma transplant.
For now, it is melphalan, it is standard. Older papers are there with TBI melphalan, which has shown more of toxicities, but currently melphalan 200 mg per meter square is the standard. And we reduce it based on the renal function and the other performance status, but we don't add any other drug to melphalan.
And nobody has tried it also in India. Dr. Anup?
Yes, the same thing. People have tried putting Bumel, busulfan with melphalan, bortezomib with melphalan. But the ultimate is, the gold standard is, I think, 200 milligram per meter square of melphalan is the standard.
We haven't used these things in here, but there is a strategy for using TBI in patients, particularly who have significant amount of plasmacytomas, so the disease is predominantly extramedullary. So TBI conditioning along with melphalan has been used, and we have used it in patients who had multiple plasmacytomas. The other ones which we have used is use of full intensity conditioning, particularly for, we have done a couple of myeloma allografts here. We use myeloablative Bucy for these patients who have progressed through melphalan autograft. So there are regimens which you can use in a particular scenario, like allografts for myeloma or extramedullary plasmacytomas being the predominant presentation. Having TBI on board is many times useful.
So what is coming up very much in an interesting way is the addition of busulfan at 130 mg per kg for 4 days and then giving standard dose of melphalan in myeloma. So these are the available literature. There is big set results. One is not showing significant significance between melphalan and Bumel. This is the retrospective data from the Petima group in Spain. The Italians did it on a non-randomized basis, and they found that adding melphalan was significantly increased the overall response rate When the Petima group did it prospectively with a non-randomized trial, again they found that the PFS was significantly improved in the Bumel group. But the phase 3 randomized trial, which was done by the MD Anderson group, did not find any significance. Actually, the standard, the problem with adding melphalan, the busulfan to the melphalan was the significantly increased rate of regimen-related toxicity. So this is still controversial. The other agent which is coming up in a big way is the addition of bortezomib. So it's a phase 2 study from the French group, adding 4 doses of bortezomib at 1 mg per meter square on day -6, -3, +1 and +4. It's a and here we have found that addition of melphalan to bortezomib significantly improves the CR rates. It's all retrospective data, and we need more clarity from randomized prospective trials. So again, the standard conditioning regimen in myeloma autotransplant is still single agent melphalan. The dose is 200 mg per meter square, and the stem cell infusion has to be 12 hours later. In patients who are having renal failure with a creatinine clearance less than 60, or if the patient is more than 65, the dose is 140 mg per meter square, followed by infusion 24 hours later. And in patients who are dialysis dependent, the recommendation is 70 mg per meter square on 2 successive days, followed by dialysis 24 hours later, followed by the stem cell infusion. Now, what would be the optimal cell dose that you will say? You have harvested, and when will you say that the cell dose is optimal? You will stop the harvest and you will go for transplant.
So ideally speaking, we would go for 5 times 10 power 6 CD34 count. I would try and get, if in single collection we're able to get by 2 volumes, I would collect as much as we can get and see if it's in excess. I would offer a patient about cryopreservation. In the new era, personally speaking, when we're using RVD upfront, I feel the patient who is going to relapse that early, who is going to go for second auto, that question of second auto is very questionable to me at this stage by reading the literature. So I would try, and if the patient is not very keen on second transplant and cryopreservation, I would try and get as much as the dose as I can. So the number of days the patient is in is less, and thereby the toxicity is less in getting out. So if I could get 10, I would go for. But for the sake of getting big number, more than 5, I wouldn't do 2 days of apheresis. But single day, 2 volumes, yes, I would.
Yeah, if I have to do a cryopreservation, I am happy with 5. If I am going for myeloma, I am happy between 2.5 to 3. That's my standard.
What's the practice in Jipno?
Between 2 to 3. I mean, we are doing myelomas at 4 degree. If it is 4 degree, it is anything between 2 to 3. We are sometimes cryopreserving for myeloma, then desirable is 5.
So say if you get a cell dose of 2 million, between 2 and 3, at what point you would decide you will go for a second harvest on the next day?
I mean, 2 is okay.
2 is okay.
With the 4 degrees, 2 is okay.
Dr. Subhash?
Yeah, myeloma autografts are easier with 2. I mean, if you're not going to cryopreserve, you can easily do on 2. As was mentioned, I mean, the first day collection is always the best day collection. Any second day collection is always ropier than the first run. So if you have got more than 2 in a single day apheresis on day 1, I think that's adequate if you're not going to cryopreserve. Certainly cryopreserving needs more use.
So this is what is reported in the literature. And so considering neutrophil engraftment, infections, morbidity, mortality and the outcomes, CD34 dose of more than 2 is enough. But if you get a CD34 of more than 4, there is significantly better or earlier engraftment of platelets. So CD34 more than 2 is enough for adequate neutrophil engraftment, more than 4 early platelet engraftment, and as a routine, I think in our center we target a CD34 of more than 4 million cells.
I have a query. For the myelomas autograft, what would be the desirable bone marrow plasma cells before harvest? I mean, after 1 line of therapy or 2 lines of therapy, or after induction, what will be the desirable bone marrow plasma cells or the desirable response before pre-transplant?
So we do a bone marrow in our center only for patients who are CR as per the criteria. So if their MBAL is negative,
so all of them has a less than 5% bone marrow.
Yeah.
In case a patient does not achieve a CR with first line of induction, to go for the second line and then harvest.
I don't think there is a recommendation based on the bone marrow plasma cell.
There is no recommendation, but the practice in
for a patient who is progressing, there is no point in doing an autologous transplant. But if a patient is multiply treated, there is still some data on doing a transplant in PR and then to give post-transplant consolidation. But based on the marrow, we have never I don't think there is a
So I gather what you're saying, to define the response,
Yes.
a stringent CR or CR or PR.
stringent
yes,
CR
it
still
does,
we can't.
but you
No,
can't
it
define
affect,
it.
yes,
We
we
don't
need a,
usually do that.
No, there are people where they have some, so like to document a complete remission, there is a biochemical parameter.
Yes.
But pre-transplant, we do bone marrow aspiration and biopsy both to document plasma cell percentage is less than 5%.
In case if it was not significant.
That is a small proportion of patients. But there are paper which has shown that if you have a plasmablastic morphology, though patient is in complete remission with few cells plasma which have a plasmablastic morphology, their progression-free survival is not good. They relapse very early. So some morphology-based paper are there, even with the complete remission on bone marrow. If you say scattered cells which are having abnormal morphology or something like that. And I think in coming years the MRD-based some criteria will come definitely before the pre-transplant MRD, what MRD you want to achieve and all.
Sorry, just a bit there a bit. There is the myeloma 9 trials as well as the subsequent trials have proven that even if you transplant a VGPR, you still can get a complete remission at the end of your transplant. So VGPR or a CR, if the patient